First of all, I'd like to thank the organizers of the European Association of Nuclear Medicine to invite me for the topic on diagnostic and therapeutic dilemmas in clear cell renal cell carcinoma, and especially the use of the monoclonal antibody G250. My name is Peter Mulders, and I'm a professor and chairman of the Department of Urology. So I'm a urologist involved in treatment of kidney cancer. First of all, I want to set the scene to clear cell renal cell carcinoma. It's not the most common tumor, but it is the most common renal cell carcinoma. And actually, you can see here that there is a definitive increase in the number of cases detected in Europe. We increased in the last 7 years from 63,000 to 78,000. And that's mainly because of the increase in incidentallomas. It's somewhat more in elderly people, somewhat more in men. And it's more common in Northern Europe and in the United States because the introduction of CT scan and ultrasound is more in those countries, and the number of incidentalloma has increased substantially. In case it is metastasized, it's a lethal disease. First of all, I want to discuss the imaging techniques in kidney cancer, and especially the use of molecular imaging there. So traditionally, the ultrasound and CT scans has been done, and the vast majority of the patients are detected with renal cell carcinoma because of that. But renal cell carcinoma is not one entity. We know there are subclassifications, especially with regard to histology. Although clear cell carcinoma, which is related to the mutation of VHL, is 75% of all kidney tumors, especially in the larger type, but also papillary type 1 and 2 and chromophobe and even oncocytoma. The last two are related to Burke-Hoch-Dubé gene mutations, but you can also see that there are specific gene mutations. In smaller tumors, and I will come to that somewhat later, the number of benign tumors detected is there, which is another reason why we need better imaging. In renal cell carcinoma, already in 1994, it was discovered that there is a surface protein, which originally was called MN and detected in HeLa cell lines, but it was finally discovered as a carbon anhydrase 9, which is actually very homogeneously expressed on the surface of clear cell renal cell carcinoma, the subtype. The functionality became also clear later on, because the functionality and the expression of CA9 in clear cell renal cell carcinoma was related to the VHL mutation. So what happens in a cell when VHL is mutation? It starts acting as hypoxia. So it is asking for oxygen, which gives a whole cascade of expression of factors, for instance, VEGF. But when the cell is acting as a hypoxic cell, we know now that CA9 expression is increased. And it's not only in clear cell renal cell carcinoma, but also in other tumor types. This mechanism is happening. For instance, in cervix, esophagus, lung, breast, colon, and brain and vulva cancer, also CA9 expression is increasing when a cancer is acting hypoxic. So we know now that we have an antibody which is called girentuximab, and we can use that antibody to determine where the CA9 is expressed. Already from 1986, when it was discovered, the monoclonal antibody G250, but one of my postdocs, Egbert Oosterwijk, so years ago, you see the development is there. And the development with the antibody is both for diagnostic, but also for therapeutic reasons. I will come back to that. With regard to the conjugation of the antibody with radionucleotide for diagnostic purposes, originally iodine-124 was used, and it showed a very high sensitivity and specificity of clear cell renal cell carcinoma, already published in Lancet Oncology in 2007 of the New York group at Memorial. We conjugated the girentuximab to indium-111 and published that in European Urology already in 2013. The advantage is there that you have a better tumor to background ratio, but you can also see here the very high sensitivity and specificity. Actually, in all patients that express CA9, it was seen on the SPECT images with indium-111. So this publication showed in 26 patients the value of the SPECT scan in almost all patients. In one patient, we did not see that correlation, and until now, we are still figuring out what the reason is for that. But in general, you can see the positive predictive value of this antibody is 100% in this diagnostic study. And this is one thing what is happening in renal cell carcinoma. So we know now that 40 to 50% of all tumors are incidentaloma, discovered by ultrasound or CT scans done for other reasons. And in these small renal masses, let's say less than 3%, we know also that 30% of these tumors is benign. So there is an unmet need to see, for instance, in this case, if this tumor, as it is pointed out, is different from the so-called cyst there. You want to know that for sure before you do surgery. And this was seen in this SPECT images with indium. Nicely seen the positivity, and now we know of a clear cell renal cell carcinoma, whereas the cyst is completely benign. We used PET imaging with Zirconium-89 because it has a higher resolution than SPECT images. It also gives a faster images, so it's more practically can be practically used, and it has a higher tumor to normal ratio than iodine has. So we investigated this in a study and published that to see what the diagnostic capacity is in diagnostic dilemmas in renal cell carcinoma. And here you can see the first patients, 17 patients. You can see in case a small renal mass is there, in case the PET is positive, in all patients we did surgery, and it appeared to be a clear cell renal cell carcinoma. For us as urologists, it's very important to know if a patient has clear cell renal cell carcinoma or non-clear cell renal cell carcinoma, but also differentiated from benign. In general, we know that clear cell renal cell carcinoma, especially in small renal mass, has a more aggressive development, and that's the reason why you want to do surgery or other means to control it. So to know beforehand what kind of histology it is, it's important. That's the additional value of such a PET scan, apart from a biopsy, which in not all cases is conclusive. So let's focus somewhat more on more advanced disease and the role of the imaging. And this is a case I like to discuss. Is a 68-year-old female she had an nephrectomy in 2015. She had a positive resection margin, and it has a clear cell renal cell carcinoma. So in March 2016, she came back with an ultrasound which is suspicious of a recurrence in the caval vein. A CT abdomen of the thorax, it was not really seen. We did an MRI, and then we saw the lesion in the caval vein, but also there was a regional lymph node enlargement. So this is a diagnostic dilemma. You want to be sure if this is recurrent tumor or is it a normal thrombus. So we did a scan which actually, with zirconium, which actually showed positivity of the thrombus, and the enlarged lymph nodes did not appear to be malignant on the scan. So I did surgery on this patient, removed the tumor in the cava, did also the lymph node dissection, and actually you can see here that the PET images with zirconium was right, because the lymph nodes were not positive on histology, whereas the thrombus had clear cell renal cell carcinoma. Another case which we had a diagnostic dilemma, or to see also what kind of therapy we should use. This is a 52-year-old man who had a left nephrectomy, appeared to be clear cell renal cell carcinoma, and in 2016 he was unfortunate to have a right tumor in his monokidney and also an enlarged adrenal met. So we discussed that, and we decided to do a zirconium girentuximab PET scan in this patient, and you can see here nicely the tumor in the monokidney and the enlarged adrenal. But unfortunate for this man, he showed metastasis in his bone on 2 spots, even in his finger. And because of the metastasis in the bone, we decided not to do surgery on this patient, because the surgery would most likely end up with a complete resection and make the patient anephric. So the diagnostic, the therapeutic approach was changed due to this girentuximab PET scan. So in conclusion, we think from this exploratory study that zirconium girentuximab PET scan can be useful as a non-invasive diagnostic tool. And we know also that it can only be used, and that's one of the limitations, that it can only be used when we know that patients have a clear cell renal cell carcinoma. In advanced renal cell carcinoma, that's 85% of the cases. In the small renal cell, renal masses less than 3 centimeter, it's up to 50% of the cases. But we know also that the high background signaling in the liver, sometimes to discover liver mets can be difficult. There are still some limitations, but the usefulness of Zirconium-89 girentuximab for diagnostic purposes, hopefully I have shown you in this presentation, because that's the other major part. And the therapy in metastatic renal cell carcinoma has evolved substantially, going from immunotherapy to targeted therapy, but also lately with the checkpoint inhibitors. As you can see here, in all risk categories, the checkpoint inhibitors have a role. But TKA combinations are still given in first line. In second line therapy, also a lot of these therapeutic approaches are tested. So this is the backbone to see what is the role of therapy with girentuximab. Radioimmunodetection I showed you. In radioimmunotherapy, we use lutetium-177 as a beta therapy to be used in kidney cancer. And for instance, this patient, unfortunate to have a multiple recurrent site on PET imaging, was treated with lutetium girentuximab. So this is the first phase 1 study with 23 patients, where you can see different dose levels with a maximum to 2590 millibecquerel. The maximum tolerated dose was shown for the first cycle. No subjective side effects actually, but the bone marrow toxicity when you combine lutetium with girentuximab was a dose-limiting factor. The phase 2 study was also done on maximum tolerable dose. You can see here the amount which was given, with a secondary with efficacy as a primary endpoint, but especially also the side effects. We did it in 14 patients, and in general you can see here the treatment schedule. First, with Indian girentuximab, the imaging, and in case it is positive, there are 2 more images needed. And then afterwards, the injection is done with a therapeutic agent, with lutetium girentuximab, and response evaluation was seen. And patients had to be seen very frequently in the outpatient clinic, especially to determine bone marrow toxicity. We did it for several cycles, up to 3 cycles, with every time 75% of the doses of the previous dose. And And this is the curve of thrombocyte count, where you can see here that you can have a significant hematological toxicity, which is recovering, but it determines the amount what you can give. What about the efficacy? In general, we see a kind of a stabilization of the disease in actually most of the patients, going from 5% to 40% in different doses. Really key, and that's the reason why we have to determine different dose schedules of therapy. So the results is actually in 7 of 14 patients, we see stabilization of the disease, and in 1 we saw a spectacular partial response. And 6 out of the 14 patients in the phase 2 had a second dose. But definitely myelotoxicity prevented actually most of the retreatments, and those adjustments had to be made. We published that in European Urology a couple of years ago, and this is actually the phase where we are in now to see what is the better and optimal therapy. So you can see here, we believe it is an effective therapy with especially stabilization. This was actually in the post-cytokine area. Retreatment is difficult. We need better schedules, and hopefully also in combination with other active agents. And one example I want to show you, when we combine it with TKIs. Because it is an intravenous therapy, we have to see if the uptake of your radionucleotide, which needs to be toxic in clear cell renal cell carcinoma, is there. And this is a study in 4 weeks and 1 week of sorafenib. But what happens if you give sorafenib? It completely shuts down the tumor vascularity, so the fact that your radionucleotide is not entering the tumor anymore. So this is one of the main reasons why the schedule should be determined, that you first give the radioimmunotherapy and then afterwards the TKA. This is also an example of a complete shutdown after 4 weeks of therapy. And you can see here what the 4 weeks of therapy is doing on the tumor vascularity, quite a rapid decrease of the tumor vascularity, somewhat more than in the 1 week schedule. So what is the future of girentuximab? And actually, these are the trials now ongoing. There is a confirmatory study on the use of Zirconium-89 girentuximab, the so-called ZIRCON study, a global study in clear cell renal cell carcinoma patients, actually in renal cell carcinoma patients, and after the surgery, you can determine in small renal mass if it is clear cell, yes or no, and what the result is there. So it's a study that will see what the correlation is, but to my impression, and I show you those results, I definitely believe that the sensitivity and the specificity is going up to 100%. The other is the dual modality. Didn't discuss that here, but also for us as surgeons, it's nice to have a per-operative imaging by dual modality imaging of with girentuximab. But definitely in the therapeutic area, the use of radioimmunotherapy with lutetium girentuximab will be explored, especially in combination with active agents, what we have now, for instance, axitinib and pembrolizumab in renal cell carcinoma, metastatic renal cell carcinoma, but also in patients who have a checkpoint inhibitor as monotherapy. The combination will be explored in a schedule that is reliable for the patient with regard to especially the bone marrow toxicity. Hopefully you will see this journal. It's an online journal where also girentuximab is published as a review, and I show you in this corona time how water also can affect our city, and I thank you for your attention.